Good morning, good afternoon, and good evening to our wonderful speakers, chairs, and audiences of the ACNS webinars. Today, we will hear two very important cerebrovascular topics with our very learned speakers and chairs. The speaker for the first session of today's webinar is a giant in the field of cerebrovascular field. He is a global president of the Walter Dandy Neurosurgical Society. It is my great honor to introduce you to our honored guest from the USA, Professor Salim Abdul Rauf. Professor Rauf is the neurosurgeon-in-chief of the Abdul Rauf Institute of Neurosurgery. He is the founding chairman of the Department of Neurosurgery at the St. Louis University, Missouri, USA. He has served as a visiting professor to over 100 universities around the globe. He has authored the main reference textbook for the bypass surgery titled Cerebral Revascularization, in which Professor Abdul Rauf details extracranial to intracranial bypass surgery. Additionally, he has pioneered a procedure for brain bypass surgery that is named after him. He has served on the boards of multiple neurosurgical societies, including the CNS, the NASBS, and the World Federation of Skull-Based Societies, and he was the 17th president of the Society of the Brain Mapping and Therapeutics. We are extremely honored and thankful to him for accepting our invitation to be a speaker at our webinars. And today is going to talk about the future of microsurgery of aneurysms and AVMs. The speaker for the second session of today is our honored guest from Japan, Professor Toru Sato. Professor Sato is the president of the Ryofukai Sato Neurosurgical Hospital, Hiroshima, Japan. He reserves his interest in the field of trigeminal neuralgia and hemifacial spasm and computational fluid dynamics and natural history of cerebral aneurysms. We are extremely honored to have him today as a speaker for our webinars, and he will be talking about his favorite topic, which is 3D multifusion imaging in neurovascular conflicts. The chair for the first session of today is our honored guest from Italy, Professor Marco Senzato. Professor Senzato is the director of Neurosurgical Department, Ospedale Maggiore Niguarda Granda, Milan, Italy. He is also the president of the Italian Society of Neurosurgery. He has acquired considerable experience in the field of vascular neurosurgery, in particular in the treatment of AVMs, cavernous angiomas of the brainstem, and complex intracranial aneurysms and revascularization procedures. We are extremely honored to have him today to chair the session of Professor Salim Abdul Rauf. The chair for the second session of today is our honored guest from Brazil, Professor Hildo Azevedo. He was the chairman of Department of Neurosurgery and the chief of resident program, Hospital de Restauração, Recife, Brazil, since 1991. And he's also a full professor of neurosurgery and chairman of Department of Neurological Surgery, University of Pernambuco, Recife, Brazil. He was the past president and vice president of the Brazilian Academy of Neurosurgery. He was the past secretary and first vice president of the WFNS and later nominated as the honorary president of the WFNS in 2017. He has been decorated with several medals of honors for his contribution towards neurosurgery in his country. We are extremely honored to have him today to chair the session of Professor Toru Sato. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to welcome both the speakers, chairs, and the audiences to this online platform of ACNS webinars. Dr. Liu Boon Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this platform to the first chair, Professor Marco Senzato.
Thank you. It's a big honor for me to chair this section, especially because I was one of the students at the St. Louis course on bypass revascularization held by Abdul Rauf several years ago, and so it's a big honor for me to be here. May I share the screen for a while? Very few slides. I'm very curious to listen what's the future of vascular surgery and what is it, especially on AVM and aneurysm, because we have several topics on the carpet. And so first of all, conservative treatment is still a choice. I hope, in my opinion, that Aruba is already gone, and we hope that the damage done for this publication is gone. And now we have to deal with the limit of surgery, especially on eloquence, the range of age. One of the main topics is how to deal with unruptured AVM, especially in young guys, in kids. I don't know. My opinion is we have two choices: to let them live without harming them, or to do something useful for them to prevent the damage. So especially in the young guys, in the kids, this is a topic that has still be debated. The second question is eloquence. Everything is eloquence, and the indication, the main problem on indication of surgery is eloquence. As you see, diffuseness, deep-seated, all these at the end is eloquence. So how to define it and how to deal with all the problem we can have in indicating surgery is still a big problem. There is a recent publication by Lawton setting how do you say the line below 6 and over 6 on the supplementary scale, but each one has to be discussed and each one has their problem. So I think that also white matter is important in the evaluation of eloquence. And finally, on aneurysm, of course, now, at least in Europe, endovascular has taken a large role in, especially in acute aneurysm. But for unruptured, the role of synergy between surgery and endovascular, especially bypass plus something endovascular, is really an important thing. So having a good relation with the endovascular team is extremely important, because you can rise the limit where you can do something. But it's important for me to stress also that we have to remember that clip is the end of the surgical training, while coil is the beginning of the endovascular training. And this is a high risk, because we can find people that knowing how to put a coil can approach very difficult situation, forgetting that there is probably a better solution by surgery. And so I think that one of the main goals at the end is to defend vascular expertise, passion, and training. And the only way to do that is to centralize neurovascular complex cases. These is just an introduction. Of course, I didn't say anything, though I am very curious and I'm waiting to listen Salem what he will do on this topic. Thank you, Salem, and that's your turn.
Thank you, Professor Senzato. Marco, you made excellent points. I agree with everything you said. I'd like to recognize you in the panel. We have experts and masters in this panel, and it's a great privilege to be here with you. I'm gonna go ahead and share my screen here. I'd like to thank the Asian Congress of Neurological Surgeons for inviting me. It's an honor to be here. I'd like to thank Professor Yuko Kato for her leadership, and for the panelists who are with us today, and the moderators. When a global leader in neurosurgery passes away, we are reminded that we live on the shoulders of giants. Professor Kano was such a giant. I remember when I was starting up my career, I invited him to the United States. He came, did an amazing course with me on hands-on for neurosurgeons about skull-based approaches in tumor surgery. What a kind gentleman he was. He has contributed to the education of neurosurgeons in developing countries like no other I know. I'm privileged to have, for the fact that I had the chance to meet him, and he will be utterly missed, not just in Japan, not just in Asia, but on the global stage. Another giant of neurosurgery, who was my mentor a few years ago, said to me these words: "You are the last of the dinosaurs, Salim." I was really taken back by that comment, because he saw all the stuff I was doing in vascular, and I was taken back by this comment, and I thought about it over the next few years to come. I'm going to share with you my experience in looking at this issue. As Marco just mentioned, there are a lot of major issues to think about the future of neurosurgery. And I want to share with you my own personal experience and journey as to why is it so that a great giant in the field of neurosurgery said that to me some years ago? What are the issues we're confronting, and what are the future directions? I think the fact is, and I'm talking about now the reality around the world. So I want to make sure this is not necessarily what I necessarily believe is the right thing, but it is a reality we're facing today. Okay. Yes, an aneurysm is more likely to be coiled than clipped in the future. It is a reality for many reasons, for training, for economics in some regions, for many issues, including advertising and so many other things. Okay. So let's start with the first situation. And what is the future of this aneurysm? Okay. So this is an aneurysm that is of the carotid bifurcation for the young neurosurgeons watching. Carotid artery left side, frontal lobe, temporal lobe, optic nerve, carotid artery, middle cerebral artery, anterior cerebral artery. Okay, because of the time, I'm going to move forward pretty quickly in these. So in this case, okay, I'm doing a surgery. I'm shrinking this aneurysm so that I can look at the perforators behind me, and I will clip this aneurysm in a very clean way. There's no concerns. We're doing this. As you will note, I'm doing all these surgeries awake in the patient, so I'm testing everything. But what is the future of this aneurysm? I believe the future of an aneurysm like this is going to be coiled in most places, okay? And that is what's going to happen, okay? Especially aneurysms that have very good neck to dome ratio. This one is slightly larger neck, but this aneurysm will be coiled in most places around the world in the future. And that's what's going to happen. Now, we have a very nice clean treatment that cures the aneurysm, but that's where we're going in the future as far as that's concerned. But for post-coiling failure, microsurgery treatment is needed, okay? So let's look at this. Let's look at the right side carotid bifurcation aneurysm. Different situation now, okay? What's happening here is this. We have a patient who underwent coiling, and as you saw here, the aneurysm after a few months starts refilling, okay? Now I'm back in a much more difficult situation. Why? Because the coils are freeing up the aneurysm. I was called by the endovascular neurosurgeon to come deal with this issue, okay? This is the future of microvascular surgeons. And I think we need to be very honest with ourselves what we're going to be dealing with. For the residents, this is a carotid artery this time, middle cerebral artery, anterior cerebral artery, a large aneurysm right here. Now, I identified the anterior choroidal artery, and I'm going to be beyond it to put a temporary clip. Now, of course, I'm doing awake testing, so I'm going to know 100% for sure.
Perfect. Let go. Perfect.
So I know 100% that I'm not occluding the choroidal artery or flow to the brain during temporary clipping. Okay.
Okay. Left toes. With your left toes. Left toes. Perfect.
Okay. What is not possible now because of the coils? What you saw in the last case, before I'm putting a clip on this kind of aneurysm, I'm going to shrink it down, because what happens with coils, I don't have the ability to do that. The clip will keep on slipping. That is a concern I'm going to have in this case. Okay. But I do not have that luxury.
There you go. You doing good? Yeah, you're doing good, Shelley. Okay.
So now what I'm doing is doing the best I can in a tightly packed aneurysm in the top, open right here. Okay. So this is a more challenging situation. The post-coiling, post-endovascular cases in the future will be more challenging for neurosurgeons. Okay. And that's just a reality. And I'll tell you what, look at what the best I'm doing. I'm going to put stagger clips. All right. Now, stagger clips in a difficult situation like this is a risky business. All right. That is something we have to recognize. My clips will keep on being pushed down. Okay. This would have been a difficult case because of perforators to open the aneurysm to take the coils out. See what happened when I put the clip? The patient says, I cannot move my hand. EEG and SSAP is totally normal. So I'm knowing exactly what's going on right away.
Well, wiggle your toe, Shelly. Shelly? Okay, good job. Can't speed your left hand.
So what am I facing here? I know exactly what's going on. The clip is occluding the bifurcation, is slipping down. So I need to very quickly, they're telling me they did a motor evoked potential, it's normal. But the gold standard, I know right away we have a problem, okay? So what am I gonna do? I'm gonna take the lowest clip and keep moving my clips up to open the bifurcation, okay? So these are the challenge. You see what I'm doing for the residents and young neurosurgeons. I have to do this. I have to keep staggering the clips away. You see the bifurcation is opening up more, okay? Right there, okay? So I keep staggering until I get to the top here, and then I will remove this clip and you will see how the bifurcation opens away right away, okay? So this is the situations we're facing more and more of now, okay? You see how that opened up.
Good job, Shelly, let go. Good.
So now the patient's fine, she woke up fine. So we're dealing with more complex situation. The reality of basilar apex aneurysms is going to be endovascular treatment with very few exceptions. I do agree with this one. I do believe that endovascular option is the best option for most basilar apex aneurysms for many reasons. There are exceptions, however, where our people need to be trained to handle these situations. If you look at this situation here, we've got a patient with a grade 1 hemorrhage with what looks like a very difficult situation. It almost looks like a blister aneurysm, okay, right there. The endovascular people said this would be too dangerous to go up here. We cannot pack this area. It's a small aneurysm, so we still have to be able to do microsurgery, okay? In these difficult situations where endovascular option, the endovascular people are telling me that is not an option here, okay? Because there's no stent they could put in that area to take care of that aneurysm, okay? So we have to be ready to handle these situations, okay? And we have to be able to address these and not believe. So that's a basilar artery, the third nerve, okay? And let's just move along here. Basilar artery, superior cerebellar artery, okay? The aneurysm is gonna be right here. You know, we're coming in from the right side, temporal lobe, frontal lobe, carotid artery, third nerve, okay? SCA, basilar artery, okay? I'm gonna be very careful. If this aneurysm has very thin wall, that will really cause a problem for us. Basilar artery, BCA, right? I'm very lucky here. This was not a thin wall, so I'm able to directly clip it right there, okay? We have to be able to do this, folks, okay? Anything at the basilar complex is something we have to be able to handle in the future for some of these situations and from that standpoint. But there are situations. There will be no option but microsurgery, okay? In these situations, we have to have a very highly trained group of microvascular surgeons. Male with a large, partially calcified, partially thrombosed middle cerebral artery aneurysm. The dome of the aneurysm. Just for the younger neurosurgeons, there is no endovascular option here, okay? There's just no, I mean, I don't want to get into a discussion about it. This is partially thrombosed. There's thrombus inside. It has calcified wall, okay? It has already bled. There is no way of putting coils in this and stuff. It'll be a disaster. I mean, you will essentially give the patient a massive stroke. So that is really not even a discussion issue. But we need to have people who can handle these situations, okay? It is not something that, you know, there are no other options. Part of operative planning. Partially thrombosed aneurysms are by definition larger than their angiographic appearance. From an operative standpoint, we will plan to remove the portion of bone that's adherent to the aneurysm.
Actually, the aneurysm is
as a
attached to the
separate
bone
piece.
completely here.
Moreover, it was important for us to be prepared to perform an ECIC bypass should that be needed. After performing the terional craniotomy, we are removing the portion of bone that's adherent to the aneurysm separately under direct vision. We start with the separation of the aneurysmal dome from the dura, which is adherent to it. Before clipping can be done.
We have to open this aneurysm. There is no way you could put clips on this aneurysm without actually opening it up, okay? So this is a different ball game, this aneurysm, okay?
The calcification required the use of the CUSA to decompress this aneurysm. To avoid lengthy interruption of blood flow, we avoided temporary clipping during this portion of the procedure. And we have to be very ready to immediately place clips once arterial blood comes through.
For this, younger surgeons watching, at this point, you should have temporary clips on. I did not want to have a lengthy temporary clipping time in this patient, but that's based on your experience and how much of this kind of work you've done as to what you feel is how you want to handle it.
At this point, I'm occluding the blood flow from the aneurysm with the dissector in my right hand and getting ready to put the first clip with my left hand. Of course, this is a large aneurysm with a wide neck requiring multiple clips. I'm speaking to the patient throughout this process, and he is doing very well.
Is it real hard? Good. Good.
Of course, this requires a real complete reconstruction of the neck area.
Only 27 when I had surgery. I was scared. Salim Abdurrauf, he made me and my family feel safe. If it had been anyone else, I don't know if I could have done it. So I guess I owe you a thank you. For me and my family, we appreciate it. This surgery really was life or death for me, and you gave me life again, man. Thank you.
So we have to be ready to take care of these issues that no other treatment can take care of, okay? So that's my view of the future of aneurysms. The question is, what is the future of ECIC bypass for giant aneurysms? Okay, if you look at this really big aneurysm right here, and us doing anastomosis, which is something that really is something very deep to my heart. It's an area I have been very involved with, and we are able to place a large bypass, completely excluding the circulation and completely curing the aneurysm. Okay, so the issue here is more complex. I think the future here is going to be as stent technology improves for giant internal carotid artery aneurysms, flow diverters will end up playing the primary role. Now, I'm not here to discuss what is right and what's wrong and what the data shows specifically. I am here to tell you what the reality is. okay? So the reality is the future of these types of giant aneurysms will be flow diverters, all right? However, bypass will continue to play a pretty extensive role in specific areas that I will talk to you about. For example, we, the vascular surgeons, will become salvage. We become the back end salvage procedure for failed endovascular treatment of complex aneurysms. So what I'm showing you here, for example, is this is a radial artery here. This patient had a coiling of a basilar apex aneurysm that failed, had another rupture later. The problem is that P1 was coming out of the aneurysm itself. So before I can go and clip it, I had to go and put a graft into the posterior cerebral artery. This is me attaching the radial artery to the posterior cerebral artery around the brainstem. That's a bypass procedure, long graft, okay? That had to be done first before I can go and clip an aneurysm that has failed endovascular treatment. So we have to be at the level that is much higher in the future as neurovascular surgeons. It is no longer the simple aneurysms that we will deal with. We will not have simple aneurysm to treat anymore, because all simple aneurysms in the future, most of them in most countries will be treated endovascularly. You know, and we can argue that and many other issues, but I'm just talking about the reality in the world we're facing right now, okay? So we have to be ready to deal with these kind of situations where we have to do these complex bypasses for complex failed endovascular treatments, okay? And that's a bypass to the posterior cerebral artery from that standpoint. That's a bypass graft right here that I put in. Now I can go in and clip the aneurysm, okay? For Moya-Moya disease, there is no alternative to microsurgery, okay? It is the best treatment based on data we have available for Moya-Moya patients to both decrease the risk of future stroke and decrease the risk of hemorrhage from the microaneurysm, okay? This is a beautiful procedure, you know, where we attach this superficial temporal artery to a distal branch of the middle cerebral artery. It is extremely low risk procedure, probably one of the lowest risk procedures I know there is in neurosurgery, okay? It is of tremendous benefit to patients. So this is not an area for, you know, discussion because there is no alternative options, okay? Beautiful procedure. I want this generation of neurosurgeons to get really good at bypass, really good at anastomosis, because this is a great procedure to become an excellent surgeon with your hands, and you are benefiting a lot of patients, okay? Next, we go to the situation what Professor Senzato just talked about, the concept of what do we do with AVMs? This here, you're seeing a complex AVM, posterior thalamus, patient bled already twice, intubated, sent to us, ventriculostomies, started to wake up, complex AVM, okay? There are no real other options for curative treatment. Microsurgery will remain the gold standard for the treatment of AVMs. That is not similar to statements I made about some other things we just talked about. It is the only gold standard for curative treatment of AVMs of the brain, okay? So, you know, some of them can be complex when they're grade 4, you know, we're going interhemispherically here, in between, to treat an AVM around the vein of Galen. But we have to be trained to handle these situations and really treat these in a way Again, in this case, I'm benefited by the fact that every time I put a temporary clip to check a vessel, I'm testing the patient. I know which vessel is a feeder, which vessel is a normal vessel to the brain that I cannot touch by testing the patient directly, okay? So I have that additional advantage in this kind of surgery, okay? So that's treatment of complex AVMs. However, despite what Professor Cenzanto just said, and what I just said, let's look at the reality of what's going on around the world. As a result of decreasing microsurgical volumes and overall decreased presence of microsurgeons on the stage, many grade 1 and 2 AVMs are being sent to radiosurgery. That is a sad reality, but it is a reality, okay? Grade 1 and 2 AVMs are cured by microsurgery 100% with low risk and experienced hands. But because of the overall result of what's going on with aneurysm surgeries and the atmosphere and the culture in hospitals, a lot of this is happening as well as a side effect. Now, you're gonna have to really reinvigorate yourself. The Professor Marco Cenzanto used the word passion. We have an amazing treatment, much better risk stratification for the patient than natural observation or radiosurgery, yet that is not being offered to these patients. And that is a sad reality, okay? So we want you to start really rethinking the situation. Be realistic. We need to have joint endovascular microsurgical teams in hospitals, but we gotta make sure where the treatment is the best, that's the treatment that's offered, okay? So we cannot fall into this trap for many things. So I'm trying to keep this conversation very even-handed, okay? I'm not trying to be biased. I'm trying to really give the right message that has to be given in these situations. So everything I showed you so far, all these cases and the lessons I've learned in this process, is the fact that I was doing them awake, so I have to show you we are obliged as leaders in the field to show you how we collected our data and what does our data show. Because the awake vascular surgery is something new, this was done under IRB protocol. The patient was given multiple discussions in outpatient clinic and discussed with the surgeon about the day of surgery, about the awake option, discussed with the anesthesiologist, we discussed with the resident, okay? So the cases I just showed you were complex cases under the study. So complex cases were defined as large, giant, partially thrombosed or partially calcified aneurysms. And for AVMs, grade 3 and above. The more simple cases were not included in this study, okay? The patient had the option to decline the awake option. Anesthesiologist also had the option to decline the awake option based on airway. So this study, this was data gathered by the committee that reviewed all the data, not neurosurgeons, totally separate committee of 9 doctors. And I want to very quickly show you the data. This was collected from 2013 to 2019 prospectively. A total of 202 craniotomies for complex cases. 162 were awake, which was 80%. And I will summarize this data for you. This is from the PAC system. They were able to go through every patient, look at so many variables. Of course, for patient data protection, a lot of these fields are covered. This is morbidity and mortality. And as you see, now, all this is under conscious, all this is listed top of anesthesia under conscious sedation right there, okay? And then this was 40 cases that were done under general anesthesia because the patient declined, and all those variables were looked at by an independent committee. This is the summary, okay? So what you're looking at here is 202 operations for complex aneurysms and AVMs. Same surgeon, same team, okay? And we directly were able to compare. So under the general anesthesia patients, we went from 10% morbidity to 4.3%. For mortality, we went from 2.5% to 1.08% in awake. Okay, so that's combined morbidity and mortality. We're talking about very experienced people who have done, hundreds of these cases before getting into this protocol. So this shows that microneurosurgery still is improving. We're still looking at ways to improve the outcome of our patients. Okay. So what is the reality now that we are in? We use the term equipoise. Equipoise meaning that if let's talk about aneurysms. If the treatment for an aneurysm, if it was an equipoise, meaning that either you do microsurgical clipping or endovascular coiling, you have equal risk and equal outcome. If that existed, what's going to happen today? The patient will undergo endovascular treatment. And I actually agree with that. If truly there was an equipoise, meaning equal risk and equal cure, equal everything, the patient would undergo endovascular treatment. Now, I do not believe equipoise truly exists in many situations. Young patient with a posterior communicating artery aneurysm, 32 years old, I don't believe that's equipoise. That supports microsurgical clipping. A basilar apex aneurysm, in an older patient, yes, that would support the endovascular treatment, okay? I don't believe equipoise completely exists in many situations, but that is the perceived assumption. And so let's talk about reality. So the future direction, when the perceived assumption is that it's equipoise, what's going to happen in most countries, the patient will be offered endovascular treatment, okay? That's just a reality that we have to be very aware of, all right? So what is the paradoxical challenge we're facing? What I showed you so far, because a large number of cases for valid reasons or maybe some invalid will undergo endovascular treatment, there will be smaller volume of cases for the neurovascular neurosurgeon. And secondly, what I showed you throughout this, what I discussed with you so far, the cases that you are going to have to deal with are going to be more complex cases. The days of simple aneurysms you're doing every week are over, okay? That's just a reality. This is the paradoxical challenge. Not only you have less volume, the cases are more complex. So that is the truth, the issue, the concern for the field of neurosurgery, how we handle this for the current neurosurgeons, the young starting up vascular neurosurgeons, and residents in training. This is a difficult problem, ladies and gentlemen. For microvascular neurosurgery, our current routine training paradigms fail in the face of this paradox. There is no way that our, how we've done it to the last decades is going to work in this challenge. We are not going to be able to produce people with the expertise, and the existing people will not have enough experience. And it fails, unfortunately, in the face of this paradox. The other element is that I've talked about before is this issue that also concerns me about the reality of a career of a neurosurgeon, okay? We have to look at all these issues and come up with a future direction. This is a Dunning-Kruger effect, a Nobel Prize winning work, which looks at your confidence in yourself versus the years you spend in your career. When one finishes their career in their residency in neurosurgery, and I remember being exactly in that position, You have a false sense of confidence. You think you're God's gift to the world. You think you could do everything. Believe me, all of us have been through this. And what happens over time, that confidence starts going downhill. Okay? Why is this happening? You're dealing with a lot of problems, mainly complications. The reality really hits. That comes to mid-career. Okay? Then as a person gets more experience, understands the literature, understands decision-making, technically gets better, it starts moving to this part of the curve, which is becoming a master, like my panel here. Each one of them are masters, okay? What is the true reality here? This, let's be honest, can take up to 30 years, okay? So by the time the neurosurgeon has achieved really where they need to be, they're in their 50s or 60s, okay? That's just honest truth of what happens, okay? There are, exceptions to that. And of course, some of, but the truth is this. So given the last slide I showed you, which is the paradox, given this thing, I've been really thinking a lot about how we're going to improve the situation. The whole idea is for us to move this curve to the left. The ideal situation is that we have neurosurgeons achieving their peak in their 30s and 40s, not in their 50s and 60s, because that's where the best research, best outcomes, best service to the patients will become. So, so this is an area that neurosurgical leaders like this panel and those who are watching need to think about quite a bit. How do we deal with the paradox I just talked about and with the Dunning-Kruger effect? How do we make this better for ourselves? Okay, so those are the things, and all of us come up with answers that we believe are the right answers, and I have thought a lot about this, and I want to share with you what I have come up with, and I hope you can support that as well. What we need to do is to hybridize our lives as neurosurgeons and as trainees. See, what all of us live in is this world where we essentially live in one hospital, one program. That's our whole world, okay? We learn from each other. We live inside a box, and all our experience is limited to that. Whereas we can have two different lives. One is our own. Let's take a resident, for example. A resident is trained by his or her excellent teachers in their program, 5 or 6 of them. But what if this resident at the same time was a student of a University of Neurosurgery, which was now being taught didactically every week, some of the major concepts by major experts in the world continuously throughout their residency, and to explore mentorship, training options, all these things. I think that could really change. The same thing applies to a neurosurgeon in practice, okay? So this is what I came up with, and I will share this with you.
Meet the ABDO University of Neurosurgery, the first online academic degree in neurosurgery worldwide. This online nonprofit US-based university offers students, residents, and fully trained neurosurgeons around the globe a range of modules, elective classes, and research opportunities to develop their knowledge in neurosurgery. Developed and established in 2021 by over 90 administrators from 24 different countries, our online degree welcomes any keen students and doctors and includes a bachelor's, a master's, and doctorate degrees. Our courses have been developed in a flexible format to suit a variety of learning styles and to support students who join from all corners of the globe, focusing on their success. Without being tied to a physical university, learn from wherever you want with the support of experienced mentors and expert guidance. We offer very affordable tuition and a scholarship program to support our keen students. Its state-of-the-art online learning platform and website, developed with a minimalist design, brings the most efficient workspace, access from anywhere you want. Neurosurgery is changing. Be part of the change. Apply today.
At least that's my solution after years of speaking to colleagues all over the world and seeing the paradoxes we're facing in vascular neurosurgery and other specialties in neurosurgery. So going back to my first slide, when my world-renowned master neurosurgeon mentor told me, Salim, you're the last dinosaur. I saw him last year when I was finishing the data for my study, the awake surgeries and stuff. And I said to him, sir, I'm not the last of the dinosaurs. And I really believe that. So I believe that that microvascular neurosurgery continues to evolve and continues to have a major impact in the treatment of patients around the world. Yes, it's going to be combined with endovascular treatments in every center in the world. Yes, it's going to deal with more complex lesions in the future than simple ones, but that just is a typical challenge that you give to a neurosurgeon, meaning it's going to be more difficult. You need to live up to it. That is a typical neurosurgical mentality, okay? So our current vascular neurosurgeons, upcoming residents, just have to be better, just have to be better. And yes, they can. So what I said is that the prediction of my extinction was overrated. I don't believe we are going to become extinct. I think we are there to really improve and continue to improve the specialty. And just from a personal bias standpoint, neurovascular surgery is the heart and soul of neurosurgery historically. You know, if you look at our giants, you know, from Drake to Yashagil to everyone else, it really was centered, you know, around vascular neurosurgery. Okay, we are not going to kill our soul. We are going to do the right thing for our patients, whatever that is. We're going to get a lot better. We will continue this journey, and we'll continue to get better at what we're doing. And each one of us is trying to come up with new ways to improve that. So I think I'm coming exactly to the last minute of my presentation. So I would like to stop now because Professor Marco has a discussion. So it has been my honor to speak with you and to give you my thoughts about the future of aneurysm and AVM surgery. Thank you very much.
Thank you very much. Excellent speech, excellent topic, and you have touched many of the great problems we have today. I would like also to stress another thing you said about equipoise, because you said that if you evaluate equipoise, now of course a patient would choose endovascular because it's less invasive, but the problem is, I think one of the main problem, and I think that one of the problem that endovascular team has to think about is that as surgery, we as a surgeon had to compare ourselves to masters. So we grew up with masters, and so I am not allowed to do a stupid thing because there is somebody else that say me this is a stupid thing, and so we think on what we do, and we have to learn. We spend our life learning from the master and confronting our procedure with the masters. I think that due to the fact that every year there is a new device, a new endovascular device, a flow diverter, a web, and whatever, they still feel to be pioneers. And so they are allowed to do whatever they want, and they are allowed to test new procedures. And this, I think, is one of the most risky situation, because I think that it's important that we as a neurosurgeon try to work with them and to transmit them the same idea that patients needs to have the right procedure and the right expertise, and not they are not on the frontier. They are just inserted in a clinical setting when there are many options. And another issue is, as you said, unfortunately, gamma knife or radiosurgery is taking over a lot of grade 1 and grade 2 AVM. And so also here we have to stress the result of surgery and how it's more effective and at the end very little harming in those kind of patients, especially because surgery changes. The general idea that neurologist has and all the other is that neurosurgery is all the same and there is no evolution. So you are there with a knife and the fork and it's always the same. But the introduction of bipolar non-stitch, for example, completely changed the surgery of AVMs. Now we are taking out an AVM almost like as a tumor. You very surrounding it. So all the damage that we had in AVM surgery, now with monitoring, with the non-stitch bipolar, with laser, with the fluorescent, everything changed. Also surgery. I remember the one once, also for aneurysm, once operating MCA aneurysm, it took half a day with the craniotomy like that. Now it's half an hour, 1 hour and a half, and the patient goes out the day after. So the progress of neurosurgery has to be expanded and transmitted to neurologists and to all other people that see our kind of patient. But would you comment?
Marco, I agree with everything you just said. Excellent points, and it's a reality. You know, I think we have done a poor job in educating our neurologists, doctors in the hospitals, the patients. You know, we're not as good at it, and so that has hurt the field. We have to be very thoughtful about what's best outcome for the patient, and we have to be passionate about it, whatever that is. If that's endovascular for that case, I support it 100%. But when I believe the best outcome in microsurgery, we do need to make that very verbally known, because we don't want patients being hurt just because somebody's trying some new technique on them with a new stent or something like that. So I think that's a reality. And I give my talk from a global perspective as to what's going on around the world. I mean, it's a reality I have to face as to what I'm watching. So that's the vision I gave it. But the points you made are tremendous. And we look forward to leaders like you, Marco, around the world to really stand up for the training of our neurosurgeons, training of the next generation. It is an art. The problem is the learning curve for microsurgery is totally different from endovascular. It takes years to become excellent in microsurgery. Young people, neurology residents are learning how to do coiling in the United States now.
Issue with Professor Salim Abdulgaf's internet. He should be back soon. Once in a blue moon, it does happen. we can take a few comments from Professor Atul Goyal in the meantime. Professor Atul Goyal, yes.
So this, there is no question that Salim has talked from his big experience and wonderful experience, and now he has seen it all, done it all, and went through the issues, went through the probably complications, went through successes, seen failures of endovascular, done some high-class work in bypasses, fine microneurosurgery. And whatever he has said is actually what has to be learned and understood by, not by young, but the extremely highly qualified vascular people. To do these kind of complex cases like giant aneurysms and AVMs under awake condition is another milestone in the subject of neurosurgery. We can do awake treatment in endovascular. You see, that is the beauty of endovascular, that you can have the person awake and you can do it. But to do awake neurosurgery for such complex tumors is not an easy job, and not many people in the world can even dream to do all these things. As I mentioned repeatedly, this is the height of microneurosurgery, height of anesthesia, height of patient compliance, and height of learning. So what I appreciate of Salim is that he wants to train young people, talk to residents 1:1, have programs where he trains young people. Now he's gone to another chapter of his life of a University of Abdul Rauf, and I wish him all the success. And I don't know exactly what is the goal and what is the ultimate and where will all this lead to, but I can see it clearly that young people wanting to do neurosurgery, wanting to do class neurosurgery have an additional opportunity, additional way to enter into it, and additional parameters to learn and develop and all these things. All in all, beautiful lecture, Salim. I congratulate you on your work, and I appreciate what you are doing for young people, for people who want to learn and do good neurosurgery, and my best wishes to you. Thank you, Salim.
Thank you, Atul. It's always an honor to get such nice comments from a master and a mentor to a whole generation of neurosurgeons. So I'm honored. Thank you.
Thank you very much. May I kindly ask one question to Professor Salim Abdul Rauf, that of the 162 craniotomies you showed, did they include any of the ruptured aneurysms or all were unruptured?
Yeah, these are all elective cases completely. I don't believe in awake surgery for acute cases. It should never be. You have to be cognitively fully with it, and you have to consent to it. It's a discussion. It is a whole process. There were very few cases of grade 1 rupture that neurosurgeons called me up and said, listen, this is a complex aneurysms, grade 1. So there were a few cases that were included that were fully awake patients. But in general, this awake surgery should not be done for ruptured cases at all. It should be only for elective cases. And I will say something, Professor Atul was very nice the way he said it. Awake microvascular surgery is really only pretty much, unfortunately, for people like on this panel, highly experienced vascular neurosurgeons, okay? And that's a major limitation. I could not have done these cases I'm doing when I was starting doing aneurysms and AVM. I was so scared about the aneurysm and the AVM itself, let alone talking to the patient about every perforator I'm putting a clip on, okay? So unfortunately, really, awake microvascular surgery is really that end of your career when you have done hundreds of, I didn't do this until I haven't done over 1,000 aneurysms on over close to 400 AVMs. I had done already. So I had developed a lot of experience. So unfortunately, it's very restrictive. That's why I have never said that awake vascular neurosurgery is a standard of care. I have never said those words. It's an option. And it's very limited in the hands of the kind of people, the masters we have on this panel, because they have achieved that level of experience. So it is very narrow as far as, how it can be offered. Thank you. Thank you for that question.
Thank you very much. We can take one short question from Liubun Singh, and Professor Hildo as well wants to ask. We'll go with Professor Hildo first.
Oh, yes, I just like to congratulate my good friend Salim. It was just a fantastic lecture. I was sorry when I thought that it was finishing. Thank you very much. Your masterful technique, and also you are trying to apply operate on awake patients now that you due to the brain tumors surgery that we have are having some experience operate on them awake. So I think that you can translate it into the vascular surgery. I would say that microvascular neurosurgery will never die, because if you are a good microvascular surgeon, you'll be a good microneurosurgeon. Someone needs to go down there, even if you don't operate on or clip any more aneurysm, but to remove a meningioma of the tuberculum cella, to remove a craniopharyngioma, or to do a hypocampectomy for epilepsy. But if you are a good vascular surgeon, you'll be a good neurosurgeon as a whole. And in the end, Salim, perhaps in the private, send me some more information about the University of Neurosurgery, that I'm very much interested on it. Thank you very much.
Thank you very much.
Thank you, Heldo. Thank you very much for your nice comments.
You?
Yeah, thanks, Raja. Thanks, Professor Salim. One question, Professor. Do you think that wasarum is the answer against an endovascular procedure in view of risk of regrowth of aneurysm by endovascular procedure? Wasarum.
You're saying I missed the word you said. You said the regrowth of the aneurysms?
Yeah, the wasarum was now known to be the reason why the aneurysm regrowth in endovascular.
Yes. So the biggest challenge has been, we didn't have time in this lecture to go through this. So for the young neurosurgeons residents are watching, the outcome of a procedure is not just morbidity, mortality, which is complications, is the efficacy of the treatment. So you have to look at two things. Did you achieve cure, and what is your risk benefit, or what is your morbidity and mortality? The problem is when we're trying to talk about equipoise, you have to include both things. So if, let's say, you have an aneurysm and you have a cure rate of 65%, yet your morbidity and mortality is the same as microsurgery, but the cure rate in microsurgery is 99%, that is not equipoise. That has been the biggest challenge in explaining to patients and neurologists this issue. Because what happens, those patients come back for further treatments, whether endovascular or the cases I had to do. The combined risk of those multiple procedures is the ultimate morbidity and mortality. It's not the one procedure. That what has been lost in translation in explaining these situations. So that has been a big issue where neurosurgery, vascular neurosurgery has failed to really put a stamp in explaining these things. So what you're saying is the regrowth of aneurysms, and I have a whole series now of previously endovascular coiling and stented flow diverted patients. I have a whole series that I can present on that have come to me for treatment. That makes our treatment more complex. It would have been easier in my hands if that patient had nothing done before. So, so Dr. Boone, you're raising a very important question. And I think as we mentor this generation and current neurosurgeons, there has to be really a lot of education about how these discussions are taking place in hospitals and units, in training programs, so that a realistic view of what things are available. For example, I have many AVM patients that have been previously radiated and embolized and then rebleed years later. The combined risk to that patient is all those years versus one curative treatment. So I think you raise a very big question. We could spend a whole session discussing it, but that is a critical question that has to be looked at by every physician recommending to a patient what to do. Cannot be just a proceduralist. This is my concern. In a lot of countries around the world, the endovascular people are proceduralists. They may be a radiologist or neurologist who do not know the natural history of diseases like neurosurgeons do. So that discussion is missed. It's just about the procedure, whereas the long-term outcome of the patient is not part of the thought process. And that has been lost because the neurosurgeon with all that knowledge is not at the table, okay? We need to rethink about this. Through the University of Neurosurgery, I really am creating platforms for really completely reconfiguring the situation under a neutral umbrella, not associated with any one society, one organization, no politics, just truly us academicians and clinicians coming together to protect our specialty and, more importantly, do the right thing for every patient. Thank you, Dr. Boone.
Thank you very much. We can wind this up, and I would like to invite Professor Marco Senzato to hear his concluding remarks. You are unmuted.
No, I have no conclusion. I think that we already said that the neurovascular surgery will have a future. I probably will have a future in special hospital, not everywhere. And I think that this is the future. We have to concentrate the pathology in special and training hospital. And probably there will be no every neurosurgeon able to do an aneurysm as it used to be. But now we have to concentrate in spatial and few trained at hospital. Another thing, I think that in Europe we lost the train, in the States much less, that also neurosurgeon has to be trained in endovascular, because it's not something we have to leave to somebody else. And so it's not easy because but being for a neurosurgeon doing endovascular is not such a difference than for a cranial neurosurgery to do spine surgery. It's not such a big difference. It's just another field, but we have to have the same mentality. So I think we also need to defend this choice. And so
I just want to endorse what Marco just said. We want this next generation who's training to be dually trained. That is going to be very important. I think that is how the field of neurosurgery needs to really continue to treat these lesions, whatever the treatment is.
Absolutely right. Thank you very much. We had a very wonderful session, and I would like to thank Professor Salim Abdul-Rauf and Professor Marco Senzato for this valuable pearls of wisdom. Before we go on to the next session, may I inquire with Professor Abdul-Rauf and Professor Senzato, would they be staying back for the second lecture? Or?
Of course.
Oh, Professor Senzato?
What? No, what? Sorry?
Would you be staying back to hear the second lecture?
No, I don't. Do I have to talk about something?
No, nothing. Just if you are interested, that's all.
No, it's okay. Thank you. Thank you very much.
May I inform our honorable viewers, we are currently watched by 815 neurosurgeons live across the world on various streaming platforms. And I would like to go ahead with the second session. I would like to invite Professor Hildo Azevedo to say introduction about multifusion imaging and NVC, and would invite Professor Toru Sato as well. Professor Hildo.
Thank you very much, Raja. I understand that we are behind the schedule, so I'll try to be quick, but I could not start off before without thanking Professor Kokato for this kind of invitation, and also to pay homage to Professor Tetsu Kano, a great friend of mine, a great teacher, a leader, a pioneer, a man who wanted just to build interested not only teaching in neurosurgery, but also to promote friendship amongst the world, amongst neurosurgeons, committed just to build bridges in the not only in the world neurosurgery, but also in Asia. So Professor Kano, I used to call him not the last dinosaur, my dear Salim, but the last samurai. I used to call Professor Kano the last samurai. So we are going to hear about neurovascular conflict. We understand that neurovascular conflict is a very blazing topic. It was raised by Dandy many years ago, later on by Gardner, but it was taken by Professor Janet in the 60s. But it's perhaps we are going to watch talk about image on neurovascular conflict, but we cannot forget that we are clinicians. So we need to match very carefully what you see on the MRI, for instance, with what the patients present on. For me, I always remember what my former mentor at Oxford used to say, be always very skeptical, because for me, it's very simplistic for you have only a vascular conflict, for this conflict to be responsible for hemifacial spasm, for all kinds of cranial neuralgias. We can discuss this later. So for me, when you go in the posterior fossa, you see neurovascular conflicts everywhere that we go, and only a few patients develop craniofacial neuralgias or hemifacial spasms and so on. So I'm very excited to hear what Professor Sato is going to say, and later on perhaps we can match everything together, put everything together and to discuss what the image provide us, and adding to the clinical picture that present by the patient. Thank you very much. I think that Professor Sato now has got the microphone.
Thank you, Hildo, to introduce Rot for NVC. So, shall we start my talk?
Yeah.
Today, I will talk about 3D multifusion imaging to depict NVC of trigeminal neuralgia and hemifacial spasm. Department of Neurological Surgery, Ryofukuisato Neurosurgical Hospital. Torusato, MD, PhD. Yes, let's start now. Objectives. In order to visualize the neurovascular contact, NVC, of trigeminal neuralgia, TN, and hemifacial spasm, HFS, for microvascular decompression, MVD, we have developed the 3D multifusion imaging. In this imaging, co-registered MRI and CTA images are fused, so that NVC consisting of artery, cranial nerve, and brain parenchyma is depicted in a single 3D picture. Contents of today's talk are as follows. Chapter 1, Technical Aspect of 3D Multifusion Imaging, Perspective versus Orthographic Projection, and Upgrade versus Downgrade Data Selection from Opacity Chart. Chapter 2, Trigeminal Neuralgia, Severity Assessment of NVC, Restoration of Nerve Shape after MVD, MVD Strategy with Imaging. Chapter 3, Hemifacial Spasm, Pre- and Post-Operative Simulation. An interesting case of hemifacial spasm caused by VA aneurysm treated by stent and coiling, visualized the NVC with silent MRA. Chapter 4, Reoperation for Recurrent Cases, Recurrent Factors and Strategy of Retreatment. Chapter 5, CFD Redicting NVC Site, Hemodynamic Detection of NVC Site. Chapter 1, Projection of 3D Images. We use perspective projection, instead of orthographic projection. See figure of Japanese crayfish. Perspective projection is better to understand the real world, as we usually see the objects with camera view. In the architecture drawing, we see the objects over the lattice door. Reconstruction of 3D images. We select data from opacity chart of the volume data. As you know, we use upgrade slope for 3D MRA and CTA, that is viewing an area of higher intensity data. In contrast, we use downgrade slope for 3D MR cysternogram, that is viewing an area of lower intensity data of artery, nerve, and brain from higher intensity area of the cistern. It is convenient to visualize borderline between anatomical structures, that is selected by a sharp triangle. These circles are sharp triangles selected for visualization of the borderline. See circles showing downgrade slope for 3D MR cysternogram. We show how to make 3D multifusion imaging. Operative photos are in the left column. Starting with 3D MR cysternogram, reconstructed by selecting lower data from the opacity chart. Look at the trigeminal nerve and offending SCA. These are similar to the operative photos. Next is 3D CTA, 3D silent MRA, 3D TOF MRA, fusion of CTA and MR cysternogram, silent MRA and MR cysternogram, TOF MRA and MR cysternogram. And finally, a 3D multifusion image of all in a single 3D picture is reconstructed here. Chapter 2, we assess the severity of NVC. We see the objects from outside operative view, looking the Earth from Space Shuttle. In contrast, from inside virtual view, looking cattle from the bucket. Severity assessment of NVC. At the operation, we usually see the offending artery in touch with the nerve. From outside, the severity of NVC is classified as none, mild, moderate and severe. From inside, severity of NVC is assessed by the circumferential percent of contact area as none, mild less than 20%, moderate 20 to 40%, and severe more than 40%. See circle. Operative simulation and severity assessment. We can find the NVC here. The left trigeminal nerve is compressed by the superior petrosal vein, SPV, directly, and the trunk of the superior cerebellar artery, SCA, indirectly. The NVC is eliminated by transposition of SPV with SCA. From outside, preoperative simulation shows severity of NVC. From inside, intraneural virtual viewpoint, the nerve is compressed and deformed by SPV and SCA from above. Over 40% of circumflex of the nerve, this is severe degree of NVC. See circles. Restoration of nerve shape after MVD. Nerve shape is restored after elimination of NVC, depicted by pre- and post-MVD images. Representative case of trigeminal neuralgia. Real site of NVC is shown at the operation. By MVD, offending SCA is transposed and attached to the dura mater, so that the compression of the nerve is released. This is a case of the former VTR. A. MR cysternogram, minimum intensity projection image. Trigeminal nerve and crossing vessel, and here is the NVC. B. This is 3D multifusion image. NVC is here. C. Real site of NVC is shown at the operative photo. D. E. F. By MVD surgery, offending SCA is transposed and attached to the dura mater, then the compression of the nerve is released. After MVD, the nerve shape is restored from bending before to straight. See circles. This case shows the orifice of trigeminal nerve, viewed from inside brainstem pons. Inlet of the nerve is compressed from above by the offending SCA. After MVD, inlet of the nerve restored cylindrical shape. See circles. MVD strategy with imaging in trigeminal neuralgia. This is a case of intraneural SPV causing trigeminal neuralgia. We depict the whole course of SPV preoperatively. For the surgical planning, if we sacrifice an intraneural course of the SPV1, the remaining SPV2 may substitute for that. We performed MVD according to this strategy. Circles show the offending intraneural SPV before and after MVD. Circles show collateral flow of SPV2. This is an operative VTR of the former case. This is an intraneural course of the SPV causing compression of the nerve. This is a case of trigeminal neuralgia without NVC. Preoperatively, we find no offending vessels around the trigeminal nerve. But the nerve shows hollowed shape. At the operation, we found arachnoid fibers anchoring the nerve. We cut the arachnoid villi. Look at the nerve restored in nerve shape without hollow, and symptoms were recovered. See circles. Chapter 3, Pre- and Post-Operative Simulation of Hemifacial Spasm. This is a case of hemifacial spasm and tinnitus, showing the NVC. The pica simultaneously compresses the nerve roots of the 7th and 8th cranial nerves. The offending pica is transposed by collagen fleeces, and both symptoms are released afterward. Circle here the NVC, circle here no NVC with collagen fleeces. This is an interesting case of hemifacial spasm. The root exit zone of the left facial nerve is compressed by the vertebral artery aneurysm. By the endovascular stent encoiling, the VA aneurysm is diminished. In Figure A, the real site of NVC, compressed by the left VA aneurysm, is visualized by 3D multifusion image of TOFMRA and MR cisternogram. In Figure B, pre-treatment TOFMRA shows VA aneurysm. In Figure C, VA aneurysm is treated by enterprise stent and coil for the first time, and followed by Elvis stent-in-stent procedure. In Figure D, elimination of the NVC is clearly depicted by 3D multifusion image of silent MRA and MR cisternogram. In Figure E, post-stent-in-stent treatment with silent MRA shows residual aneurysm. In Figure F, left VA markedly moved after stent-in-stent procedure. Silent MRA shows stented and coiled VA aneurysm with minimum metal artifact. Circles here the NVC, and here no NVC. Chapter 4, Reoperation for recurrent cases of trigeminal neuralgia and hemifacial spasm. How to detect recurrent factors by imaging. This is a case of recurrent right trigeminal neuralgia after 5 years. Adhesive granuloma caused by Teflon prosthesis is depicted before retreatment. See circles. Granuloma around SCA is resected piece by piece, and symptom is recovered. This is a case of recurrent hemifacial spasm. Adhesive granuloma of Teflon prosthesis is visualized before retreatment. Adhesion is sharply resected and the offending pica is transposed to dura mater, then the symptom is recovered. See circles. Chapter 5, CFD Predicting NVC Site. This is an ongoing study. Hemodynamic analysis detects the site of NVC. Areas with high magnitude of wall shear stress, WSSM, and low mobility of vector variations of wall shear stress, WSSVV, indicate the site of NVC. This is a case of trigeminal neuralgia. WSS of CFD may presume NVC site. We find here areas with high magnitude of wall shear stress, WSSM, and low vector variations of wall shear stress, WSSVV. See circles. This is a case of hemifacial spasm. WSS of CFD may presume NVC site. We find here areas with high magnitude of wall shear stress, WSSM, and low vector variations of wall shear stress, WSSVV. See circles. These findings may indicate the location of the site of NVC. Take-home message. The 3D multifusion imaging can provide clear depiction of the anatomical architecture of the NVC before and after MVD. This imaging may be useful for decision-making process to execute and follow up MVD in patients with trigeminal neuralgia and hemifacial spasm. CFD analysis may predict the site of NVC. Thank you for your kind attention. Thank you. This is a closing slide of our hospital and affiliated facilities, and an anniversary festival. Thank you for your kind attention. I hope to visit your beautiful country in the near future. Thank you.
I think that mainly to the residents, I can make a few comments about this kind of neuralgias and about what I think about the neurovascular conflict. I think no one would disagree that when you separate the vascular conflict for instance, the trigeminal nerve, you can see that as a very successful operation, that the pain will vanish. But on the other hand, what we can see when you have a patient with trigeminal neuralgia, and most of the conflict time are done by the SCA, and most of the conflict you see on the shoulder of the nerve, which has been on the anteromedial aspect of the nerve. And on the other hand, mostly of the trigeminal neuralgia is characterized by pain in V1 territory. And sometimes when you see the conflict on the trigeminal nerve, you understand that in the posterior fossa, the motor nerves are more frequently associated with the V1 segment of the trigeminal nerve. And so why don't you see what I call hemimastigatory spasm? It's a very, for me, it's a puzzle. On the other hand, when you see hemifacial spasm, why at the same time you don't see geniculate neuralgia? Geniculate neuralgia is very, very rare indeed. I have had the opportunity to operate on 3 cases in my life. On the other hand, when you see patient with vagoglosopharyngeal neuralgia, also you would expect, if the neurovascular conflict was the only thing to blame for the pathology or for the pain that the patient presents, I would expect to have some spasm of the pharyngeal musculature. So for me, it's still a puzzle. I think that the conflict is very simplistic for you to say is the only thing to be blamed. On the other hand, if you understand that this conflict is related to the very tiny section of the trigeminal neuralgia where the central myelin starts to be done by the Schwann cells, and this portion of the nerve is very close to the brain stem. Is on the first 5 millimeters of the nerve. So sometimes you can see the conflict away from these 5 millimeters, and still we blame the conflict for the. I don't say that we are not, I'm not denying the importance of the surgery, but there are some questions that have been inside my brain for many years. Also, you can say that if you have the conflict, you induce a demyelination in the nerve. That's why the pain comes along. So these people should have some other pathology and perhaps some alterations of the sodium metabolism or sodium channels for this problem to arise. So is a cause or consequence this conflict. So that's I'm a bit skeptical just to say that the conflict is the only cause of the trigeminal neuralgia. I think that, as I said, you see a lot of conflicts everywhere you go in the posterior fossa. And also, when you go to the operator on peak on aneurysm, we have a conflict of P1 with the third nerve. We never saw any spasm of the third nerve, by the way. So there is got to be something else apart from the mechanical thing of the mechanical pressure of the vessel over the nerve. So, but we need also, if you have a good image, you should match what you see on the image together with what the patient presents on. That's my idea. Is that what I usually try to teach my residents, that you should always be skeptical. And this also should be a matter of further research for understanding of this very challenging pathology, which is a very troublesome for the patient. I have seen patients with a revolver in their hand wanting to commit suicide because of the pain. And the surgery will release this, no doubt, it really is, but you need to understand and to go a bit deeper, be a bit more thoughtful about the pathophysiology of this cranioneuralgia or hemifacial spasm, etc.
So I'll wind this up officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to sincerely thank both the speakers of today, Professor Salim Abdul Rauf and Professor Toru Sato, as well as the chairs, Professor Marco Senzato and Professor Hildo Azevedo, for their time and support for the ACNS webinars. Thank you, Dr. Liu Bun Seng, for my co-host, and a special thanks to Professor Shubin from Shanghai, who has been our mentor for the webinars, and he has arranged the broadcast of today's webinar, and there are around 850 participants on all streaming platforms. So until we all meet on the 21st of August, it is bye-bye from all of us. Thank you, everybody, for joining.